Welcome to the Who, What, Why podcast. I'm your host, Jeff Schechtman. The idea of informed medical consent has been a long-time fundamental principle of medical ethics. However, the ways in which that consent has been granted, especially to minority groups and more specifically to African Americans, has been uneven and sometimes criminal. Certainly the U.S. Army Tuskegee experiments were the penultimate example and reverberate to this day with respect to African American populations being unwilling to get vaccinated against COVID. The care and treatment of COVID patients in minority communities has also raised serious ethical questions. The degree to which this pandemic experience informs us to do better in this area is still an open question. One we're going to talk about today with my guest, Harriet Washington. Harriet Washington is the author of the previous book, Medical Apartheid, which won the National Book Critics Circle Award. She's been a research fellow in medical ethics at Harvard Medical School, a senior research scholar at the National Center for Bioethics at Tuskegee University, and the recipient of a Knight Fellowship at Stanford. She lectures in bioethics at Columbia, and her new work just published is Carte Blanche: The Erosion of Medical Consent. Harriet Washington, thanks so much for joining us on the Who, What, Why podcast.
Thank you for having me, Jeff.
Well, it's great to have you here. Talk a little bit about the origins of this idea of medical consent. It really, from a legal perspective, goes back to the mid-40s. Talk about that.
Well, medical consent actually is a lot older. Simple consent where a researcher or doctor says, I'd like to try X. I'd like to try this medication on you. And the person says yes or no. That's consent. But the more precise variant, that's what you're talking about, informed consent. And you're right, it does emanate from the 1940s. It emanates from the end of World War II, when it was American prosecutors and doctors and ethicists who went to Nuremberg, Germany, to confront the Nazi doctors who were the architects of the Holocaust. They basically were murdering, practicing genocide, harming dramatically people who were Jewish, Polish, anyone they didn't like, but mostly Jews. And they were doing it under the guise of medical treatment or medical research. So they were perverting medical research to basically harm and kill people. And American doctors and prosecutors called them out for that and talked of the need to have a global standard that would be very precise and very careful in the way that you ask consent. It's not enough, they realize, just to ask someone, yes or no, won't you do this? You have to give them all the information they need to make an intelligent choice about whether it's in their best interest to engage in the research or not. So you've got to tell them what you're planning to do, how you plan to do it, what you're going to be testing, all their other options other than being in your research study. And you have to let them know that no matter what they have signed and no matter what they have been paid, they can always leave the study anytime they choose to. And that's informed consent. And that became part of our law in the 1940s, but it was almost immediately watered down a bit because researchers found it too constrictive.
When this law originally grew up in the 1940s, to what extent was it anticipated that it was a problem here in the U.S.? The first idea, as you talked about, was trying to create some kind of global standard. To what extent was there concern whether or not the U.S. would live up to that standard?
Good question. The global standard was enacted in order to punish the Nazi doctors, in order to say, here are the things a doctor, researcher should do, and you have violated them. So the focus was on Nazi doctors because, as Jay Katz had mentioned, the sentiment was something along the lines of, we need these kind of laws for Nazi barbarians, but we don't need them for American researchers and doctors who are moral and ethical and would never do such horrible things. So from the beginning, even though the rationale was given that we need a global standard, the idea was only certain people needed to be held to that standard. And as you can well imagine, that was a disaster. When we began enacting in our law, the Code of Federal Regulations, tenets of the Denver Code, we started abandoning some of them because they were too restrictive to researchers. And what happened was, over the years, more and more researchers had wanted not to go to the trouble and expense of getting individual informed consent. So they began applying to the government for waivers. We want to do a study, but we don't want to have to do informed consent. Give us a waiver so we can just enroll people without even asking their permission. And that happened. That happened in the military frequently. And the more dramatic case within the memory of many of us is what happened with the anthrax vaccine that was tested on soldiers who was not FDA approved for inhalation and anthrax. It was tested on soldiers, and no one had to get their permission. President Clinton had actually issued a waiver, a blanket waiver for the Department of Defense, saying you can test these things without getting permission. And so soldiers were first forced to take them, and it became a nightmare. Soldiers who refused were punished, sent to jail sometimes, dishonorably discharged, stripped of their military pensions, punished severely. And soldiers who did take them very often fell ill.
Are you surprised the degree to which this history, and I assumed you started working on this project before COVID, the degree to which this history is so much at play in the issues that we're dealing with today in the context of this pandemic?
I'm not surprised at all because, unfortunately, and you're right, I've been concerned about this for a very long time. Ever since I learned that in 1996 we passed two changes to the Code of Federal Regulation that gave blanket permission for researchers to enroll people in studies without asking their permission. That's where I became gravely concerned. But yes, the things that tend to escalate this kind of abuse, this kind of involving people in research without getting any permission, are things that increase a feeling of urgency. Things like, for example, wartime. We have a war to win. It's a matter of life or death. We may not have enough resources to do everything we want to do properly, and the pressure is on to cut corners. That helped to exacerbate the anthrax vaccination given to soldiers. The idea was the enemies of the United States might be deploying anthrax as a biological weapon. We can't have our soldiers, incapacitated by it. They need to be protected. So this vaccine is an emergency, and we don't have time to go through normal channels. And the same thing happened with the COVID pandemic. First of all, there's the fact that we knew so little about this new emerging infection when the disease struck our shores. Uncertainty is another thing that tends to trigger this. But certainly, the knowledge that we're in a fight against time, against a biological enemy that we didn't understand well, and that we had definitely too few resources. We didn't have the dedicated expertise that we would have had not Trump dissolved the committee dedicated to dealing with pandemics. We didn't have vaccines yet or any effective medication. We didn't have enough doctors and nurses. We just didn't have enough of anything. In those situations, the pressure is always on to cut corners any way that you can. And frankly, getting consent from people is sometimes one of the first things to go. One of the first casualties.
Tell us a little bit about the ways in which this became a significant problem, a more significant problem in the African American community.
It became a bigger problem in the African American community in a myriad of ways. First of all, a lot of research was already being done on African Americans without getting their consent, but this was illegal. It was being done illegally. It was still being done, unfortunately. So you had, unfortunately, this habit of thought. Frankly, for 4 centuries, African Americans' bodies and tissues have been procured and they've been forced into research that is not strictly legal, but the law was not observed when it came to them, and sometimes it was legal. They've been further victimized by residential segregation. The fact that you find African Americans confined to living in certain areas. And the interesting thing is that for a long time it was established by law in this country. I mean, racial segregation is our form of apartheid, right? But even after this was banned in the 60s, residential segregation has continued. In fact, David Williams told me that, Professor Dr. David Williams at Harvard University, an extremely esteemed professor of public health, he pointed out to me that in order for us to achieve racial parity in housing, 2/3 of African Americans would have to move somewhere else. So there are pockets, these enclaves of African Americans, Hispanic Americans, forced to live in the same area together, which makes it easy to target them. Very often, modalities that are being tested without consent were being tested by ambulance attendants. They're carried on ambulances. They'd go to the scene if someone fell by a trauma, and then they would start the research. You had ambulances in LA that were only trolling the areas where African Americans and Hispanic Americans lived. So even though, in theory, everybody is vulnerable to this, and of course, many whites have been harmed as well and dragged into studies as well. But when you engineer things so that areas where people of color live, then you end up with people of color in the study. The Polyhue study was really interesting in that regard. I looked at all the cities. There were 32 cities originally targeted by the study. Most of them were one calls majority minority, which is unusual. They were cities in which most of the people who lived there were African American. Places like Detroit, places like Washington, D.C. So the thing is, you can easily engineer vulnerability so it affects people of color. But I really want to make the point, it's extremely important. I'm not saying this is only a problem of people of color. It's a problem for all Americans. We're all vulnerable.
Have you seen an increase in awareness or sensitivity to this issue as a result of the pandemic? Does it suddenly take on a new meaning now?
I think people are cogent enough to be afraid that this is happening. Unfortunately, it's difficult for them to know that it's happening because most people, I lecture around the country very frequently. Before the pandemic, I was on the road all the time. And whenever I go to a city where I know these non-consensual studies have been conducted, I would always ask the audience, who here has heard of, say, the Polyhue study? Who here has heard of the ROC study? Almost never would anybody respond in the affirmative. People would have no idea. And yet those studies had been held right in their city. So, but now with the pandemic, what's happening is that people are no longer able, hospitals and nursing homes are closed institutions. You know, you can't go to the hospital to follow and check up on your loved one. You can't go to the nursing home. And that's, necessary. I understand that. But what that means is people are aware that not being able to witness what's happening on the floors means that things could be happening with their loved ones that they would not be aware of. So they may not know, but I think there's heightened concern about this issue.
Is there a danger in this issue that, like so many other things, that medicine in this case and research and all the positive things that are potentially part of this become so politicized?
I would argue that it's exactly backward. We are here because of politics. The decision to remove informed consent from medical research is largely a political decision. It's something that, for example, and an economic decision. The FDA requires people to complete their studies in a few years. That's a lot of time pressure already. And one way of doing studies more quickly is to not go to the trouble of individual informed consent. It takes a long time to explain to people all the information you have to give to them. And then, of course, you're always faced with the chance that people, when they understand what you want to do, are going to say no, making it harder to enroll someone. So the desire for waivers and dismissals of consent is very much a political one. It's not based on best health care, although the rationales often talk about that. But you have to understand when you hear people say that medical research is a good thing, en masse, medical research is a good thing, but individual research studies are not always good, and research is always risky. There's always risk involved. Even in the best designed, most ethical studies, that element of risk is what makes research research. We're doing research because we just don't know. We hope the modality will help people, but we can't know that. We hope that nobody will be harmed, but we can't know that. Only when the study is completed do we know what's happened. There have been, and sometimes studies have to be ended early because damages happened very quickly that nobody anticipated. There have been studies in which people were very hopeful but had to be shut down because people began dying. So we have to understand that medical research is inherently risky, and that's why informed consent is so important. When you undertake that risk, you have to know what you are risking. And unlike treatment, where you can trust and expect your doctor to care for you and do the things that are dedicated to maximizing your health and wellness, that's not research. Purpose of research is not to maximize your individual health. The purpose of research is to come up with answers and treatments that will help other people in the future who will benefit, other people who will benefit. They may hope that it will also benefit you. That's certainly the hope, but there's no guarantee that, and that's not the focus of the research. So getting people's consent is absolutely essential, not only for ethics, the obvious ethical questions. I'm really shocked that we are discussing this after Nuremberg. I mean, that should be all the evidence anybody needs, but also for people's safety and dignity.
How is this being looked at today within the medical research community, more specifically in universities and in the medical profession in general?
I can't speak for how the medical profession sees something. I can only speak for what the people I've spoken to and the people I've read about seeing them. Unfortunately, the people who are conducting the research that dispense with informed consent, by and large, don't want to speak with me. I find that interesting because they do speak to some people. In general, and this is in general, I've been working on this issue since at least 2006. And I have seen that there's often publicity, there are often newspaper magazine articles. They are laudatory. These are articles that praise the researcher and talk about the great benefit to mankind that will emanate from the study. Now, that's an error. What you should be writing about is a great benefit to mankind that you hope will emanate, but very often they don't. They trespass into that, science fiction category of predicting the future and saying this will be great, which is exactly the line that researchers say. Jay Katz, the late Jay Katz, a wonderful medical ethics giant from Yale who passed away some time ago, he's called this the therapeutic illusion because very often people are led to believe that this treatment is going to treat them and they're getting some cutting-edge new scientific treatment that they're privileged to get when really they are being used to serve the purposes of other people who will benefit in the future. So researchers tend to speak with people in general who they can be pretty sure are going to write positive things. That's not the case with me. I've had many attempts to speak with researchers I wrote about in the book. I get to talk to their press offices sometimes, and they always ask me, what kind of story are you writing? They're looking for some kind of confirmation that I'm going to write something that's uncritical. Of course, I can't say that, and I don't get to talk to the person. So I have to make my judgments based on what they have written and published about the study and what they've written and published elsewhere. And so that's what I do.
And does the current awareness of and research about the COVID vaccine, how does that play into people's feelings about this, do you think?
Well, first of all, I'm not convinced many people know about this. These laws that were passed in 1996 I spoke of, that changed the Code of Federal Regulation, changed it from saying every American must be given the right to informed consent to saying that if you're a trauma victim, a very wide category of patient. If you're a trauma victim and you become a research subject, no one has to ask your permission. No one has to even tell you that you're in research. That is a huge change, but the average American is totally innocent of it. No one has told them. There's been no transparency. And I wrote this book in part because I was so concerned that people are completely unaware that this right to informed consent is being eroded. And my fear, of course, is we're going to wake up one day and it's going to be gone. And people will have no idea what happened.
Is there discussion of this in medical schools today?
Again, I do a lot of talking at medical schools. I know people who are on staff. And so I know some of the discourse in medical schools, but I don't pretend to know it all. I can tell you what's in the medical literature, though. I can't tell you what, all the medical schools are saying. There probably is no consensus on this. But you don't hear many people voicing or writing of their concern about this. What's published, vastly represents the people who support this as an opportunity to do research. And so if you go do a search at PubMed, if you go through the medical literature, you'll be hard pressed to find many criticisms of it. Ethical criticisms have bounded. You can find articles dealing with individual studies like the polyheme study of artificial blood. There were some really illuminating and well-reasoned opposition studies written about that. But for the most part, it's not what you're going to find in the literature. For the most part, you're going to find physicians who are conducting this research um, basically defending it, talking about what a great boon to mankind it'll be when their product is finally approved, talking about, and some of them, since I've been raising the alarm about the racial disproportion, I've noticed some publications that seek to defend themselves. They'll say things like, we're doing these studies are non-consensual and we're not affecting Black people more, or Black people aren't really concerned about this. And I'm thinking, nothing sounds guiltier than someone, defending themselves, something they haven't been accused of. But okay, as I read these papers, one thing that the glaring, you don't have to be a scientist to appreciate this. The glaring error in these papers is often that when you read the fine print in the papers, it turns out that they asked about relatively few African Americans, and the few they asked had higher rates of expressing disapproval, which invalidates the claim they're trying to make. A lot of defense in this, and a lot of people explaining to you why this is all right. But if they really think that it's acceptable, why is it hidden? Why was there no transparency? Why don't Americans know about this? I don't understand why you would hide something that you truly believe is a positive thing to do.
Is there any talk of federal legislation to address this issue?
Not that I know of. Not yet. I hope that there will be.
And what would be the ideal framework for that?
Well, what I would like to see happen is these two, this waiver and this change in the law from 1996 needs to be revoked. We need to remove that from the law. What's interesting about this is I know a great deal about the abuses of medical research, even when people had the legal protections of informed consent. So it's clear to me that even if one could make a good case to me of a situation where this would be a good thing, no one has yet, but it's possible, I would still say no, because we are not ready for it. We have not shown our willingness to preserve informed consent when it was the law. We're not ready to dispense with it because the same things happen every time. You find groups of people who've been medically marginalized, people of color in particular, sometimes poor people, sometimes people with certain disorders. These people are always the ones who become the victims, disproportionately harmed. We are not ready for a law like that, even if it were positive. And I've seen nothing positive about it, frankly. What I do see is it saving money for people. And I need to add that some of these studies have very dramatic conflicts of interest. In one study of using hypothermia, doctors usually try to treat hypothermia to save people's lives because it is a killer. But in Baltimore, they are actually inducing hypothermia in people. They're creating it. And the New York Times, and the New Yorker article, they boasted of targeting African American men for this. So, trying to treat hypothermia, trying to induce hypothermia is a mistake. And there has been no evidence it's going to help anyone. These kind of things we simply are not ready for, and we should not allow. Maybe one day we'll be ready to see whether this is something that could be effective and have some kind of benefit, but I see none now.
Is there a degree to which the pharmaceutical industry is complicit in this?
Yes. The pharmaceutical industry has control over a great deal of medical research. I wrote a book entitled Deadly Monopolies in 2011 that traced the commodification of medical research, which used to be governed by medical researchers and medical institutions. And their goals were to be benefactors of mankind. These were universities and researchers who were trying to assuage disease and to be seen as the heroes of medicine. So when we had polio as a scourge in this country, you had researchers competing, dramatically with each other to be the first one to come up with a polio vaccine or a polio cure. The needs used to be driven by the needs of the American people. Now the needs are driven by the profit motive, by the desire of corporations to maximize the profit on their patents. They have a patented molecule. They turn it into a medicine. They want to maximize patents, which means what? They sell it at the highest price that Americans are willing to pay to stay alive. That's why we have cancer medications that now cost $1 million a year. And by the same token, they know that dispensing with informed consent, among other things, is going to allow them to conduct research more quickly and more quickly maximize the profits on their patents. So from their point of view, this is financially the right move to make.
And finally, talk a little bit about the kind of reaction that you're getting to really bringing this issue up right now, to talking about this issue in our current environment. What are people saying to you? What is the reaction you're getting?
So far, I've been talking to a lot of physicians and medical students. And not to put too fine a point on it, I was a little nervous. I wasn't sure how people were going to react, but I'm not a person that lets that, affect what I do. So I just soldiered on. And what I found so far is that medical students in particular are deeply concerned, and practicing physicians are too. The interesting thing is that doctors are researchers, but when they have their physician hat on, they have a slightly different job. Not slightly different, a very different job. They're trying to maximize somebody's health and wellness. With their researcher hat on, they have a different role. And that role can be conflicting sometimes, conflicting for others because what they're trying to do is make sure the study is completed accurately and ethically. But their focus is not on individualizing the health of any one patient. They do what they can to do that, but that's not the point of the study. And frankly, in cases where the patient's health is in conflict with continuing the study, sometimes it's the study that's most important. So it's a conflict for them. So I'm hearing from a lot of doctors on basically how concerned they are about this. I have yet to have heard from doctors who think that I'm making a mountain out of a molehill. I haven't heard from doctors who are defending removing informed consent from the table. That doesn't mean there aren't any. We know there are some. Some of them are doing the studies, right? But the people I'm hearing from are concerned about this. The doctors are really concerned that this is happening and I'll put it this way, they express discomfort with this, just as lay people express discomfort with it. I'm beginning to wonder who really wants this, aside from the people who are making a great deal of money and who are, basically achieving some kind of goals from it that don't involve patient care. I'm really not seeing much diversity so far.
Harriet Washington, her new book just out from Columbia Global Reports is Carte Blanche, The Erosion of Medical Consent. Harriet, I thank you so much for spending time with us.
Yes, it's been my great pleasure. Thank you for having me.
Thank you. And thank you for listening and for joining us here on Radio Who, What, Why. I hope you join us next week for another Radio Who, What, Why podcast. I'm Jeff Sheckman. If you like this podcast, please feel free to share and help others find it by rating and reviewing it on iTunes. You can also support this podcast and all the work we do by going to whowhatwhy.org/donate.